New England. Please welcome Dr. Linda Longbleel.
Thank you, Dr. Rimmer. And I want to thank everybody who made today possible. I want to thank Alex for making so many arrangements and helping me get up on this bar stool. I have a lot of practice getting up on bar stools, but it's always nice to have a little help. And this is my preferred way of speaking. So, and I want to thank Zoe and Alicia and the whole team, and of course a special thanks to Dr. Rimmer for making it possible for me to be here today. Thank you very much. It's really an honor. It's really an honor. So, I do not have any conflicts of interest pertaining to this presentation. My dream in life, though, is to be funded by Big Pharma. So far, though, I haven't had any luck. And Dr. Rimmer mentioned that I have a law degree. I do have a law degree, and I did practice for a while, but it's been a long time. And so if you need legal advice, please consult someone who practices law locally. Don't take anything in this presentation as legal advice. You know, I went back to get a PhD because I like teaching people much better than fighting with them. So, so I'm really glad to be here today. All right. And also, I want to thank Dr. Rimmer invited me because I co-authored an article with Dr. Monica Mitra and Dr. Angel Miles and Ian Mora about in 2022, and it appeared in Health Affairs. There was a special issue in Health Affairs on disability, which was great. It was such an opportunity for us, of course, but also I think for the disability community to have articles, a whole issue devoted to disability in that very important journal. Also, a particular thanks to one of my co-authors, Dr. Stephen Kay, who contributed some of the data and the policy analyses for this presentation. And I list there the presentation that he shared with me, from which I took this data. So, thank you, Steve. All right, so I wanted to start by talking about how many people have disabilities in the U.S. population. Well, there are a variety of surveys, and they all measure disability in different ways, with different questions, different methods, phone calls, or paper surveys, or internet. It's just a variety of different ways of getting data, and so they come up with different results. So, the National Health Interview Survey estimates that about 9.1% of the U.S. population has a disability. These numbers are all from 2022, by the way. The American Community Survey estimates that 13.4% of the U.S. population had a disability in 2022. And the Behavioral Risk Factors Surveillance System, which is the one that the CDC usually relies on, says that 28.3% of the population has a disability. Because one of my personal mantras is moderation in all things, I'm going to go with the American Community Survey's estimate of 13.4% for the U.S. population. And I wanted to compare it a little bit to Alabama's disability, the prevalence here of disability in Alabama. So, as I said, in the United States, the prevalence of disability is about 13.4%, give or take. And in Alabama, it's a little bit higher, 16.9%. And as you can see below, that is also, there is a slightly higher prevalence in Alabama of all kinds of disability, all types of disability, any disability, visual disability, hearing disability, ambulatory, cognitive, self-care disabilities, and independent living disabilities, just a little bit higher here in Alabama. And of course, disability affects people of all races and ethnicities, and that's reflected here too in the data. So you can see here that, again, in the United States, about 11.3% of whites have a disability. In Alabama, it's a little higher. Same pattern, a little higher for people who are Black or African American, and a little bit higher in Alabama still. Something is interesting, and I'll be honest with you, I haven't figured out why. Maybe you can tell me. But the one ethnic group, and these numbers won't add up to 100 because I added Hispanic Latino in here, and it's measured separately because it's an ethnicity as opposed to a race. Long discussion around that, I'm sure. But anyway, I'll leave that to the Census Bureau. In the United States, the rate of disability among Hispanics or Latinos is 10.5%, whereas Alabama, it's a little bit lower. And I'm not really sure why. I'd be interested to hear what people's thoughts are, might be about that. Asians, 5.2%, and in Alabama, slightly higher. Native Americans, 15.8% in the United States, and in Alabama, 20.7%, so about a quarter higher. And then other races, again, it's about 10.6%, and then a little higher here in Alabama. So. And of course, disability affects people at all income levels. It is more prevalent among people at lower incomes, but disability, as we all know, can affect anybody. All right, so Dr. Rimmer told me that there'd be a lot of students here, and he said I should make sure everybody understands the difference between Medicaid and Medicare. I teach in this mid-career fellowship program for people interested in leadership in the disability field. And it's a really interesting group of people. We have a lot of health professionals with disabilities. We have physical therapists, occupational therapists. We actually had a music therapist once. We have physicians from time to time. And we have a lot of parents of people with disabilities and professionals with disabilities themselves. And I find that they always come to the program, many of them, not everybody, but many of them come to the program confused about the difference between Medicaid and Medicare. So I thought I would try to clear it up for all of you today, just to make sure everybody's on the same page. So Medicaid is a public program for people with low incomes and assets, okay? Low incomes and assets, and that's important. It covers people with disabilities, elders over 65, families with children, and in some states, other folks. Like single childless adults. Medicaid does not require that you have a work history. That may change in the near future, we'll see. But that's an important point as well. Medicaid is jointly governed and funded by the federal and state governments, okay? It's both federal and state. They call it cooperative federalism. And the federal government sort of sets some ground rules, and then the state has some flexibility within those ground rules to cover different populations or maybe cover some different services. There are some services and populations that are mandatory, and we don't have time to get into that today, but and others are optional. But the federal government sets a floor, and the states then they add or subtract or modify as within certain parameters. So. The federal government currently reimburses states for 50 to 83% of Medicaid costs based on the state's average per capita income. So the higher a state's income, the lower their reimbursement, okay? The lower their Medicaid reimbursement, because they figure you don't need it as much. Alabama's reimbursement rate is 72.84%. So for every $100 that Alabama spends on Medicaid, the federal government reimburses it $72.84. Okay, does that make sense? Okay, so almost 3/4. Medicare is really totally different in terms of its structure. It is a purely federal program, purely federal public program, no state involvement whatsoever, okay? You either have to be 65 or you have to be disabled. You can also have end-stage renal disease, and I think maybe ALS, but for the most part, you have to be 65 or disabled. And you have to have worked, okay? You have to have worked. You have to have enough of a work record, paying your Medicare tax, that you qualify. There is one other option, though. if you are disabled before the age of 22, okay, and you don't have much of a work record, and you have a disabled, retired, or deceased parent who does have a sufficient work record, you can get Medicare based on their work record, okay? So someone who's getting disabled child's disability benefits through Social Security can get Medicare on their parent's record if their parent is disabled, retired, or deceased, okay? So another really key fact about Medicare is there is no income limit, and I should have put on this slide that there's also no asset limit, okay? No income limit, no asset limit. So that's really important too. So with Medicaid, you have to have a low income, and you have to either be a person with a disability, an older person, a family with kids. In some states, others, you don't have to have a work history for Medicaid. In Medicare, you do have to have a work history or a parent with a work history. But you do not have to have you can have a high income, and you can have high assets and still qualify, okay, because you worked and you paid into the system. All right, so let me ask you, would Jeff Bezos qualify for Medicaid or Medicare if he retired? He'll probably die with his boots on, I think. But what do you think? How many of you would say that he's going to vote for, he would qualify for Medicaid? Just raise your hand. Would he qualify for Medicaid? Good, you were listening. How many of you think he would qualify for Medicare? All right, okay. Okay, try to remember that, okay? Every time you think about the difference between Medicaid and Medicare, I want this picture of Jeff Bezos and his rocket to pop into your minds, okay? All right, good. So yes, assuming he worked and earned a salary early in his career probably, and paid his Medicare tax for at least 10 years. You do have to have 40 quarters. 4 times 10, 4 quarters in a year, 40 quarters equals 10 years roughly. So he would qualify for Medicare if he worked and paid, got a salary and paid into the system for at least that amount of time. But he would not qualify for Medicaid, okay? Keep that in your mind. He makes too much income and his assets are too high to qualify. He is above the Medicaid income and asset limits. But as I said, he would qualify for Medicare, assuming that he paid in. Okay, so let's start focusing more narrowly on people with disabilities. People with disabilities experience what we call a cascade of disparities. And I want to recommend to you a really wonderful article by Gloria Cron and her colleagues. She wrote this in 2006, and she talked about the cascade of disparities that piles one after another on top of people with disabilities. She was focused on people with intellectual disabilities, but I think these same types of disparities cascade on top of all folks with disabilities. So there are disparities in equitable access to health care. There are so many of them. I have a feeling I don't have to tell a lot of you what they are, but as Dr. Rimmer mentioned, there are a lot of disparities in equitable access, and everything from inaccessible exam tables, inaccessible diagnostic equipment. There are lower rates of mammography among women with disabilities, lower rates of prostate screening among men with disabilities. There are disparities in preventive care, which is one of the reasons that folks get the secondary conditions like heart disease that Dr. Rimmer is mentioning. There are also disparities in health promotion practices. I know that's what NCPAD's mission is all about. And I really think it's a wonderful mission because a lot of people with disabilities aren't told about the importance of health promotion and don't have access to health promotion. I can use some things, some mechanisms, some equipment at the gym, but I can't use all of it. And that is definitely a barrier. I myself have a lifelong disability. If you saw me getting up here on the bar stool, you would have noticed that. So these things certainly affect me as well. There are disparities in attention to care needs. Direct care workers are not paid nearly enough, and there aren't nearly enough of them. And so there are severe disparities in attention to care needs. And on course, on top of those things all pile up on top of adverse health and behavioral health conditions. And some of those are the disability itself, but as Dr. Rimmer mentioned, they are also secondary conditions. And preventing secondary conditions is really, really important. I know for me, having had to deal with the secondary conditions that I've acquired over my lifetime, UTIs and things like that, has frankly been more challenging than dealing with my underlying disability. So, okay. So, people with disabilities have much higher rates of unmet needs due to cost, okay? So if you look at this chart, and this is from the National Health Interview Survey, which Dr. K kindly let me borrow, you'll see here that 20% of people with disabilities are represented in the bright red bar at the top. 20% of people with disabilities who answered the National Health Interview Survey said that they didn't get care due to cost, compared to 7% of people without disabilities. 21% said that they delayed care to cost, compared to 8% of people without disabilities. 14% said they skipped or took less of their meds due to cost. And 20% said they didn't fill a prescription due to cost. And when you added all the different needs together, there's one or two that I didn't add to the slide. People who mentioned they had any one of these above unmet needs, 34% of people with disabilities said that they had at least one of these above unmet needs, compared to 12% of people without disabilities. So cost is a huge, huge factor for everybody, but especially people with disabilities. Medicaid covers about 1/3 of working adults with disabilities, about 1/3. You see here the bright green piece of pie up there at the top. That's Medicaid. Those are people who have Medicaid only, okay? You can get, even though they're different in some situations, you can get both Medicaid and Medicare, okay? If you're on Medicare, but you do also have a low income, there are quite a few people who fall into that category. We call them dual eligibles because they're dually eligible. They're eligible for two programs, Medicaid and Medicare. And I hope I didn't just confuse you by telling you that. And then you see that 7% of people in the right-hand little carve out there have both Medicare and Medicaid. So Medicaid covers about 1/3 of working age adults with disabilities. Oh, did I get that? There we go. All right, so Medicaid, fortunately, thank goodness for Medicaid. Medicaid reduces unmet health care needs for disabled adults ages 19 to 64 by quite a bit. So if you look here on the left, again, Medicaid is in the bright red. You see that 23% of people who have Medicaid say that they had an unmet health care need. And if you had both Medicaid and Medicare, it went even lower, down to 18%. Now, Medicare only folks, Medicare does help them some for sure. These are people who only get Medicare. 32% of them said they had an unmet health care need. And the Veterans Administration actually does comparable to having both Medicaid and Medicare. Only 17% of vets say that they have an unmet health care need. But compare all those to employer-based insurance. So 30% of people on employer-based insurance say that they have unmet health care needs. 39% of people who buy their own insurance individually say they have unmet health care needs, and then look at the uninsured folks, okay? 68% of people who are uninsured say they have unmet health care needs. So compare Medicaid and Medicaid plus Medicare, 23% and 18%. Compare those to employer-based insurance, individual insurance, and especially uninsured people. Because a lot of people on Medicaid, frankly, if they didn't have Medicaid, would likely be uninsured. So, okay, there we go. Let's talk about the Affordable Care Act, okay? Let's talk about the Affordable Care Act. The Affordable Care Act was passed in 2010. It was quite a contentious process, but they finally got it through. And it did a lot of positive things to improve access to health care for everybody, including people with disabilities. It reformed private health insurance to prohibit pre-existing condition exclusions. The way I got interested in health policy was I was in law school, actually, and I got a flyer from a group of women with disabilities who said that they had trouble getting health insurance because of their pre-existing conditions. And I was, like 22 years old and had a lot to learn still about the world. And I was shocked that somebody could turn me down because I had a pre-existing condition. I didn't know that they could turn me down for insurance. And I suddenly realized why my father always used to say to me, Linda, always hang on to your Blue Cross Blue Shield, which I always did. You should always make sure you're insured. So the Affordable Care Act eliminated pre-existing condition exclusions. Does everyone know what those are? That's where you have a chronic medical condition, and for that reason, the insurer says that they won't sell you health insurance, okay? Or they'll charge you a much higher premium. So that's what a pre-existing condition exclusion is. The Affordable Care Act also provides income-based premium subsidies to people with incomes below 400% of the federal poverty level, which is about $62,600 for one person. Now, that might seem like a lot of money as an income, maybe. It doesn't get you that far in Massachusetts, I'll tell you. But anyway, but insurance is really expensive. Insurance is really expensive. And the older you get, the more expensive it can get. So it is really important that the income-based premiums go up to 400% of the federal poverty level. As your income goes up, the premiums do go down. They don't give everybody the same subsidy. It's income-based. There's a sliding scale. But it is really helpful to a lot of people. Also, the Affordable Care Act improved access to employer-based insurance, and it permits young people under age 26 to stay on their parents' health insurance. I know that a lot of you are here as students, and probably some of you are still in your 20s, and my son is 20. He's at college at UMass Amherst, and he didn't realize that it was because of the Affordable Care Act that he could stay on our insurance after he turned 18. It used to be that after you turned 18, or in some cases maybe 21, they would kick you off your parents' insurance in most cases. So it's really important that now young people under the age of 26 can stay on their parents' health insurance. We call, in the health policy field, we like to call young people the young invincibles. Young people who very naturally, who Mother Nature has hardwired to think that they will never get hurt or never get sick. We call the young invincibles, and if left to their own devices, often young people will not want to buy health insurance because they'll figure, I'm never going to get sick, which it's a natural, it's an instinctive kind of perspective. So, but their parents know better, so their parents will keep them on their health insurance. And this actually has been one of the main things that has increased access to insurance over time. So, also, the Affordable Care Act does permit states to expand Medicaid eligibility to people with incomes below 133 to 138% of the federal poverty level, depending on what exemptions you get, which is around $20,815 to $21,597 for one person. States get a 90% federal match. They get a 90%, and maybe even 95% in some cases, federal match. That is, so right now, Alabama gets what did I say, 72 or 78.25 or 72.85, over $70 match for every $100 it spends. Well, if in states that have expanded Medicaid to everybody whose incomes are below this threshold, they get about 90% of a match. Okay, 90%. So they get $90 for $90 for every $100 they spend. Okay? Currently, Alabama has not expanded Medicaid, so they don't get that 90% for this program, but we'll see what the future will hold. So, anyway, you can see here what the impact of the Affordable Care Act was. The uninsured rate fell among all age groups, okay, all age groups. The Affordable Care Act passed in 2010, and it was phased in. But one of the first things that was phased in was that provision that said that young people could stay on their parents' insurance up to the age of 26, 19 to 25-year-olds. So you see, in the top left, the orange line, you see here it starts at about 33%, so about 33% of young people between the ages of 19 to 25 were uninsured in 2010. Look what that line did. Look how sharply it descended. That provision was implemented right away, and you can see that in the next year even, it fell by at least probably about 5 to 7%, and then it kept falling really dramatically. So that down here at the bottom, on the far right, by 2023, that percentage was about 13%. So it fell from about 33% to about 13%. That's roughly a 20-point drop. That's huge. That is absolutely huge. And you can see that it dropped more than any other group. So, and all the groups fell, but the uninsurance rate for all the groups fell, but it fell the most for younger people. Now this shows you the rate of uninsurance by disability status. And you can see here that the blue line is non-disabled people, and the kind of reddish-orange line is disabled people. And you can see here that actually non-disabled people are more likely to be uninsured than disabled people, and that is because some disabled people are on Medicare or Medicaid. It's not a huge difference, but it's there. You can see here that once the Affordable Care Act was passed in 2010, the rate of insurance, the rate of uninsurance, the percentage of people who were uninsured started to gradually fall. Then it fell dramatically between 2013 and 2014, and the reason for that is that the pre-existing condition exclusion prohibition for adults kicked in 2014, and also the subsidies, probably more, even at least as important, the subsidies kicked in 2014. They phased the law in because it just took time to get everything up and running. So, and it went up a little bit, and then it went back down. So you can see that by the end of by 2023, the rate of uninsurance among non-disabled people had fallen from roughly 22.5% or 23% to about 13%, roughly a 10% drop. And it went from roughly 21 or 22% to just a little under 10%. So maybe like a 11 or 12% drop in that time period. So, so it fell among all groups, including non-disabled people and people with disabilities. All right. How much time do I have? I might need to, let's see. Well, I'm going to tell you this because it's important. So just basically, the purple line in the middle is Medicaid. Okay, the purple line in the middle is Medicaid, and that shows you just how important Medicaid is to people with disabilities. So, like I said, it's about a third of people with disabilities who are covered there under Medicaid. It's huge. All right, so I want to talk about the article that inspired Dr. Rimmer to invite me here today. So in our article, we talked about the disparities that people with disabilities experience. And then we proposed some ways to expand access for people with disabilities and hopefully reduce some of those disparities. So we talked about a Medicaid buy-in for working disabled people. There is a Medicaid buy-in for working disabled people, but in many states it has a relatively low income threshold. and asset threshold. It still has a little better, definitely better, absolutely better than traditional Medicaid. But in many states, it still has a fairly low income threshold. So, for example, in a lot of states, the income threshold is at 250% of the federal poverty level. So that's about $37,650, okay? Which, you know, is certainly better than having it to be much lower, but it's still a fairly modest income for a lot of people. It still can restrict people's work productivity, their ability to work full-time. Maybe they can work part-time, but they might not be able to work full-time. So it does still hold people back. I'm grateful for it. I'm grateful for any Medicaid buy-in program that people can get adopted in a state. You know, I think if we felt that if you eliminated the income and asset requirement, as one or two states do, that you would really kind of free people up to be fully productive, much more fully integrated into society, and able to participate in the community to their greatest extent. We'd also proposed, said we'd like to see a Medicare home and community-based services benefit. Right now, you can get home and community-based services after you're discharged from a hospital under Medicare, but you can't typically get them on a long-term basis. And this is why people end up spending down to Medicaid and, you know, having to spend all the assets they spent their whole lives accruing and having to impoverish themselves. So we felt that probably one of the most humane ways to support people would be to have a Medicare home and community-based services benefit. In addition, the medical necessity standards sometimes can hold people back. Have many of you in this room, I imagine you may have dealt with medical necessity standards? How many of you have encountered medical necessity as something that you've had to deal with at some point? Yeah. Medical necessity. Right now, medical necessities is very medically oriented, functionally oriented, and it doesn't really, it's sort of just what you need to barely function is what you're entitled to. And it doesn't tend to emphasize some of the things that disability policy in general has tried to emphasize, like independence, self-determination, community integration. It hasn't tended to emphasize that. There are some exceptions, though. Delaware does talk about independence and community participation in its medical necessity requirement, and that's wonderful. Similarly, the Medicare homebound requirement says that you can only get services that help you maintain yourself in your home. Every time I read that requirement, I feel my hair start to catch on fire because, again, it just flies in the face of everything we've been trying to do in terms of promoting independence and community participation. All right, so unfortunately, I don't foresee any of these changes, the changes that we'd really like to see happening anytime soon. What's really on the table in the current climate are things like this. Let me just say that the House of Representatives passed a budget reconciliation bill the other night, and what that means is they established a broad outline for what the budget should look like and where cuts should be made. And one of the things they decided was that there needed to be $880 billion in cuts in healthcare costs and other things. So a lot of people who pay close attention to these things do anticipate that a lot of this could come out of Medicaid, maybe other programs as well. And so here's where this may lead us. Right now, I mentioned, as you may recall, that Alabama gets $70+ of a match from the federal government for every $100 they spend. Well, that would end, and states would get a fixed budget. And so just a lump sum of money, that's called a block grant. There could also, another alternative is that the amount of money that the federal government would pay would be capped per person. So there'd be a limit per person. that the federal government would pay. And again, if the state wanted to provide more services than that, they'd have to make up the excess. And sadly, this would have the greatest impact on high-cost programs, people with high medical needs, high-cost needs, and people with disabilities, unfortunately. It could potentially, who knows, but it could potentially lead to cuts in home and community-based services. Oh boy. Thank you. 5 minutes left. It could lower the access to home and community-based services, and it could reduce or even reverse the state's efforts to move people from institutions to the community. So those are some of the potential changes. It could also lead to states imposing work requirements. The states have tried this several years ago. I believe it got struck down in court, but it might come back around again. It might not save as much money as some people might think because, oh, there's something missing here. Okay, good. All right, yes. Okay, let me do that on the screen here. All right, because the bottom line is that a lot of people who are not in the labor force are people with disabilities of one sort or another. Maybe they're not on SSI, they're either on SSI or they're on SSDI, so they are officially disabled under the government standards, or they report work limitations, or they'd be considered disabled under the standards of the American Community Surveys, and a number of them are in poor health. So you wouldn't necessarily save a whole lot of money by implementing this standard. Okay, so there would also be potential changes to the Affordable Care Act. They might reduce the federal reimbursement to the Medicaid expansion states from 90 to whatever. They might do that. And potentially, there's one estimate from American Progress that potentially 15.9 million people, just people in general, could lose Medicaid or CHIP, that's the Children's Health Insurance Program, in 2026 if the states drop their expansion. That's one estimate. I'm sure there are others out there, but that's one estimate. They could change the amount of subsidies. They could reduce the amount of the subsidies, again, making it harder for people to afford their insurance. Or there's even been talk, once again, about repealing and replacing the Affordable Care Act. They tried that before in 2017, and it didn't work. They couldn't find something better that everyone would support, so the Affordable Care Act stayed in place, but that could happen. Also, Medicare, there could be some changes to Medicare. For the last couple of years, probably due to the pandemic, it's been possible to get telehealth services through Medicare. That reimbursement is, on the verge of expiring or has expired, and so it seems as though they may just let the telehealth reimbursement expire, which is really a shame because that did increase access for a lot of people. It did. Additionally, under President Biden, a provision was passed that would allow Medicare to negotiate drug prices directly with pharmaceutical companies, and the reason for that was to reduce costs. Right now, Medicare isn't allowed to do that. Individual plans that provide Medicare do that, and so Medicare isn't fully able to use its market power. There's talk now about repealing that provision and stopping Medicare from negotiating drug prices directly with pharmaceutical companies. So